So Kim comes up to me while I'm just starting into my spinach salad. So it's a great way not to get nervous, because all I can think about is, do I have spinach between my teeth? That's all I'm thinking right now. So anyway, so I'm here, on behalf of the Canadian Medical Association. I'm working there for almost 4 years now. And before I arrived, the CMA had been long involved in CAMI and a variety of different kinds of activities and roles, and had spent a lot of its energy trying to make sure that the Kirby Commission went ahead and that we'd end up with something like a Mental Health Commission of Canada. When the first reports came out from Kirby, though, I can assure you that the physicians around the board and the physicians on the core committee on healthcare and promotion were kind of like horrified to see the personal stories that were inside the Kirby report, and horrified and extremely defensive and angry. And a lot of the docs didn't believe this could possibly be true. And they wanted to do something about it, and they weren't quite sure what that something might actually be. And I have to confess, when people first started talking to me about it as well, I didn't know what it should be either at all. And I'm a public health physician. Public health medicine spends no time on mental health issues or mental illness at all. So it was a huge learning experience for all of us. The first thing the board did was form a board working group. I think what I want to emphasize to you is that it was taken extraordinarily seriously. We achieved a budget for a 5-year time period, and we were actually given a quite substantial amount of money for an organization of our size in order to make sure we got some work done. They were very, very serious. And what we realized was that we had to put together a longer term plan. You can't just handle this by doing something for a few minutes at a time or for a year. You have to actually put out a plan for 5 years, and that's what the board actually approved. And the big focus in the plan, there are 3 foci, but the biggest focus is stigma. And our issue is we don't want to be part of the problem, we want to be part of the solution. And it's hard work because you feel under attack a lot. When you're coming to meetings like this, it's very easy to point the finger at physicians, and other healthcare professionals, but I'm here on behalf of physicians, and that power discrepancy is a huge problem to deal with. So some of the activities that we decided to take right away were to get together with a whole bunch of other physicians who were as interested as we were: Canadian Psychiatric Association, the College of Family Practice, and the Canadian Pediatric Society. And we started talking at the table. They had a huge amount of experience and knowledge to bring. And we realized that we needed a group of doctors to get together, hear the academic information about stigma, and then start talking about where we should go from there. So that's what we did. And in August or September of just last year, in association with Canadian Psychiatric Association's annual meeting, we had a group of about 40 doctors and some other people, doctors but non-MDs and people from the community and so forth. We got together in a room and had some very blunt talk. And from that, we had a series of recommendations. And so what I wanted to share with you were some of the issues and activities that they are recommending. And I've got maybe 3 or so minutes left, and I want to just tell you what my concerns are, how hard this is going to be. It is going to be very hard to do this. So the number one thing we learned was we have to figure out how to incorporate direct contact with consumers into physician training. My informal inquiries into this have, I found out quite horrifyingly that, number one, it isn't done that much. It is done some places. Some programs have recently been canceled. Some of the programs are voluntary, and the students don't want to do it. Oh my God, that means we really have some work ahead of us in order to make it absolutely essential to incorporate this kind of training into medical school. we figure at this point we even have to train the trainers. If the teachers are allowing these things to be dropped from the curricula, then they have to be taught themselves what the importance is. And we feel that probably one of the most important ways of doing this, and you have to remember, doctors are we're kind of obedient people in our own disobedient sort of way, but when you get your license, you then have to prove every single year that you are competent in your profession. So I belong to the Royal College of Physicians and Surgeons as a specialist in community medicine. And every year I have to prove to the college that I've maintained my competency in that area. If you're a member of your family practitioner, you have the College of Physicians, or you have the College of Family Physicians of Canada, CFPC. And you have to prove every year, and it's all regulated and organized. And if you fail to prove, you could lose your license. You lose your license, you have no job. So it is really quite strict. And people who are in practice can have their practices reviewed. An external person comes in, looks at all of your charts, and tells you whether or not you're practicing good medicine. Believe me, this isn't a daunting and intimidating experience. But we have these things called core competencies, and that's one direction to work, is to make sure that not just psychiatrists and not just family physicians have core competencies in mental health, but every single practitioner of medicine has core competencies in mental health. Because right now, just as I told you, College of Family Practice, the community medicine specialty group, they didn't make sure that I knew anything about mental health. You know, if you're a pediatric gastroenterologist, I don't know, not so much. You know, a neurosurgeon, an emergency room physician, a respirologist, and that's one of the big steps. And so I congratulate Canadian Psychiatric Association and the College of Physicians and Surgeons for the initial work that they're doing on that. And I'm quite happy to be recently invited to sit on that group. So the mental health continuing medical education for physicians in practice, I think you already got the point. Once you get out of medical school, it doesn't stop. So continuing medical education is extremely important, and I think you heard Phil Upshaw talk today mention a couple of times that we've got a module that's going to be going out on Stigma, on online continuing medical education, CME. These are expensive because you have to have them fully approved. So each CME module costs $80,000 to $120,000. And when I mentioned about changing the curriculum, you need permission to change the curriculum by hours of education being offered. I want you to understand what a tough road to hoe this is going to be to get these changes, but the determination of various groups in this is really quite profound. So in the meantime, while those things happen, we also are working in close collaboration as we can, like I say, with other medical organizations, with other healthcare professionals, licensed healthcare professionals. We have a table where we get together, and we talk about things like recovery models. So wrote an essay with Nessa Martin on what the recovery model is from physicians. So believe it or not, I told you where the research has to go. And in my mind, the research is entirely for physicians, and there's tons of other research stuff, but for physicians, the research is all behavioral. It's about how to actually incorporate kind of right-minded thinking about mental health and mental illness into the medical curriculum and the ongoing training of physicians. And we have to make sure we beat that into them instead of out of them, which is currently what happens. Learning indifference and hardening attitudes happens because of overwork, because of what you're shown inside your environment, because of rules and regulations that isolate and separate you from the people that you're working with. So that's the part that I want to emphasize. So I think I did go a couple of minutes over, but I thank you very much.
Okay, hi, my name is Ren Seal, as mentioned. Just want to tell you a little bit how I got here today. was going through university and experienced some significant mental health challenges. As mentioned, I was diagnosed with schizophrenia. And at that point, just wanted to give back in some way, but couldn't at the time because I was so ill. And by the time I recovered, I decided to start a mental health club on campus at SFU, Simon Fraser University, called Students for Mental Wellness, just to get involved and start volunteering with other nonprofits, learning and meeting people and trying to figure out what we could do to help, and started running events and a hiking program, and realized there's a lot of work to do. Met Kelly Anderson, who was supposed to be here yesterday, and sends her regrets. She was quite sick, but she was involved with a number of new initiatives. One being the Institute of Families for Child and Youth Mental Health, which is a new national nonprofit, and so I got involved with that. And as Mr. Upshaw mentioned earlier, people with lived experience need to be engaged in research, but not only research. Provincial and federal legislation, policies, programs, and services and supports often engage consumers with simple survey or focus groups, if at all. And what we need is a national framework for engagement in all of these areas. And people with lived experience, including their family members, and this is a core distinction. It's not just engaging the person with the mental illness, but it's their whole family. It's their caregivers, their siblings, their uncles and aunts or grandparents, who are all also affected. And those people also have their own services and supports for them to cope with what's going on with the person suffering. And so these core constituents have to be at the table as equals in developing research policies, programs, legislation. And so we're working to do that. We've set up a provincial family council in BC, which is comprised of people from across the province in all different, from all different backgrounds, all different parts of the family, all with personal experience of mental illness, not necessarily themselves, but a close family member or themselves. We have youth on the council, which I'm a part of. And we're engaging with policymakers on a provincial level at this time, and on some key provincial committees in BC, engaging in different activities and policies. And this is what's needed. So we're working to set up these councils in every province of the country, and it'll be coordinated by the Institute of Families nationally, which will then go on to try to engage people nationally on a federal level. And so that's a core part of what we're doing. One of the initiatives is called Family Smart, which we've trademarked the term, and Family Smart will be like what Heart Smart is to the cardiovascular disease, or Ocean Wise for sustainable seafood. Family Smart will be an evaluation program for policies, whether they're research or legislation or services or programs, to go in and say, is your program family smart? Have you engaged the family? Are the other family members being taken care of? Do the consumers have any input on the services that are offered? But all the criteria is going to be developed in the next year or so, and we'll be working on that. But eventually, if we have a national engagement framework, we'll be able to develop much more engaged policies, and I just think the outcomes will be beneficial to service providers and the consumers. So we can talk about that if anyone has any questions after. Thank you.
Okay. I have a lot of anxiety coming to do this today because I feel a little bit like I'm outside of a gated community and I've been invited in for the first time. In 21 years, I've never been part of a process with people who have so much power. And I guess part of that is being a social worker, being a graduate of the social work program here at Carleton, which is very structural feminist, and having survived that as a male, because it becomes really important to understand, I guess, what it was like to be a part of a group where I was asked on a regular basis to represent the male perspective on issues. And I thought, I don't have the male perspective. I have my perspective. And I guess part of that is I want to talk to you about that today because I have certain biases that I'm bringing, and I want to really talk about the fact that bias is a really important part of stigma and discrimination. Sometimes I do training with the educators and the guides at the National Gallery around how to work with people who are struggling with psychiatric difficulties. And I often start my talk with the fact that I actually don't believe that mental illness exists, that it's a social construct, and it's used to encapsulate all of the different disorders, diagnoses that people experience, and that this stress is real. The disorders are real, but that we use different terms for political and social reasons, and I understand why we do that, but in 21 years of sitting with people, it becomes very important to me not to use those words, but to understand the meaning that it plays in their lives. So if someone comes to me and says, I have this diagnosis, but I don't know what it means. I have my little pocket DSM that sits on my desk, and we pull it out and we start looking through it, saying, well, what does this mean to you? Does this resonate? How many of these criteria do you think you meet? Let's talk about that. What do your family think about this diagnosis? So it's really about contextualizing it. So when we're looking at priorities and challenges, I think it becomes really important to identify how bias is just inherent in how we interact with the world. There's a psychologist at UCLA, his name's Jim Hopper, who talks about the fact that probably unconsciously, within 1/8 of a second, we decide whether an interaction is positive, negative, or neutral. And I think how do we work with making those kinds of split decisions, and how does that affect our behaviors? How does it affect the questions that I ask? So it becomes really important to look at just all the different roles and all the different reasons why we do the work that we do. And sometimes I'm sitting with people and I'm thinking, am I asking this question because I want to know or because this is useful to them? Like, who are we doing this counseling for? And always assessing that question is a really important part of understanding how we're going to be effective. Who are we working for? And part of it is I have to admit, I want to keep my job. I'm working with people because I like the pay. So that's a part of the reality. And to put that on the table, and people say, oh, you would do this job for free, wouldn't you? No. Well, being a social worker sometimes feels like that. But it becomes really important to say, look, I am who I am, and I bring all of the different aspects of my experience to this job. How are they going to be helpful to you in your experience? Because so often, the labels, the diagnoses, when someone comes in and says to me, well, you know, it's just like diabetes. I say, well, help me understand, what kind of diabetes are we talking about? Because I don't know what diabetes is. And so, did this start as a child? Is this because, you know, gestational diabetes during pregnancy? So I never assume that anything that someone brings me is something I have knowledge about, because my experience of it is different than theirs. And so being able to reflect that back and to have the openness to say, I'm not really that competent. I don't have all the answers. And so that was one of the pieces that I think came up, and I really appreciated, you know, hearing about the fact that professionals don't always feel competent, and that there's an overemphasis on competence. I also sometimes do workshops for our employee assistance program, which Carleton University happens to be one of our clients. And I encourage people to be functionally incompetent. And they always react to me and say, well, what does that mean, being functionally incompetent? I say, we have to have areas that we are not perfect at. And the more we're able to accept that, the more we're able to do that. And I bring functional incompetence to the work that I do with clients because I think that's the reality. And when they put me up on a pedestal, I ask them to make the pedestal lower because I don't want to break anything when I fall. So it becomes really important, I think, when we're looking at research priorities, to understand that bias is a part of how we design things, how we do things. It includes all the categories that we use, the language. When we think about evidence-based, a little bit biased in that respect because in the community we just see that as something that we have to put on funding proposals in order to get them. And so we don't often have time to look at, when you think about being a community mental health program that delivers long-term service that is open-ended. So as long as someone needs my counseling, I'm there. We have 2.5 employees for this city. And we have a manager who is 1.5 days a week. And we serve as many people as we can get through our door, and that means sometimes having a waiting list up to 18 months. So that's one of the realities. And so when I'm looking at wanting to do research, it's really important to say, where do I want to put my energy? And we'd love to be able to partner with people, but that takes time too. So for me, I guess I'll end with the fact that I think the research really needs to broaden to look at context as much as possible, doing qualitative research, being able to capture people's narrative, their story, and really the uniqueness that every person has. So thank you.
Thanks. I was actually just reflecting on what perspective I was supposed to bring here, and I'm less and less sure, but I'll try to give you a little bit, just a touch of background on where I'm coming from and where I think we need to work towards to address stigma, and I'll focus a little bit on healthcare providers. So my own background, I am a psychiatrist. I've done a lot of work in outpatient care, inpatient care for many, many years, assertive community treatment, so a multidisciplinary form of care outside of a hospital setting, and more recently in much more of an administrative role. Part of what shaped my thinking over the last while, I had actually the privilege of being on the Ministers Advisory Group for Mental Health and Addiction, and we'd come out with a report, Respect, Recovery, Resilience, Recommendations for a 10-Year Strategy for Ontario. And the interesting part from that experience was that really you realize when you're with a group of people for an extended length of time, working on a project, working on a potential 10-year strategy, that you have a lot of biases. And when you interact with persons with lived experience, families, a variety of professionals with a variety of backgrounds and a variety of perspectives, you realize that you actually have a fair number of biases yourself. And the more you get to know people, it's hard to keep those biases. So really, to combat stigma, I think you really have to get to know various constituencies. And we don't do that very well as healthcare professionals, in my opinion. So when we're trained as healthcare professionals, and our exposure, and I'm talking in generalities, is really towards a very select population when it comes to mental health. So as a physician, you kind of grow up in a hospital. And many of our professionals do. Nurses, social workers, occupational therapists, psychologists. Not all, but that's kind of the training setting. And who do you see, especially in an acute hospital? You see people who are in a lot of distress, in emergency situations, coming into the hospital, not in good shape, and increasingly spending very little time in the hospital. Someone comes in and they leave in 14 days. No one leaves particularly well. They're better than when they came in, they're not in an emergency, but they leave still kind of unwell. And so the whole concept of recovery, the whole concept of people being able to recover and getting jobs, getting a better social circle, reconnecting with family, having hobbies, getting involved in sports, having a life is really not something all healthcare providers have an opportunity to see. So you can bring in, from my perspective, as much training as you want, but I think training with respect to stigma only does a very little bit. You need to expose people to other people's lives. So you have to expose healthcare providers to families, to persons with lived experience across their lifespan, not just in an acute phase. And that came really clear to me after working in the hospital, working on an assertive community treatment team. You actually get to see someone in a hospital, out of a hospital, and through the recovery process. And you do a lot of work with families. And you have a different perspective once you're able to do that. And too few of our healthcare providers actually end up leaving the hospital sector. So the stigma associated with mental health is actually quite understandable. So the real goal needs to be to ensure that in training, and then afterwards in practice, I think people need to see the full range of what people can experience. So we don't tend to have people rotate through community settings outside of the larger institutions and get that exposure. So until we do that, I think we can continue to bring training in, and it's very valuable to have people come in and talk about their experience, families, persons with lived experience, but I think you need to kind of live it yourself. You have to see that happen. You have to make a personal connection. And that's very hard to do unless you get out of your institutional environment. So one thing that we really have to do is expose people in a real way to persons suffering from mental illness. The other thing that I think is a challenge, and the reason we need to address stigma overall, is really about quality care and quality service. And as a sector, mental health and addictions, I don't believe we do a terribly good job. We can talk about stigma towards persons with lived experience. We have tremendous amount of stigma towards each other. I felt stigmatized as a psychiatrist in a group where at many times you're seen as quite evil. And I don't think I am. And I think people also had biases towards the psychologist, towards we had a social worker, we don't ourselves understand each other's roles in the provision of good care and good service. So until we stop self-stigmatizing, we as a sector are never going to move forward. I won't even tell you the battles about what's more important, mental health or addictions. And frankly, in many ways, people who really suffer have them both. So it becomes a totally, in my mind, distracting argument. So we really have to stop doing that and act as a sector. The last piece I'd like to just comment on is we have to do more work on understanding multidisciplinary care, because we need to bring the strengths of many individuals and perspective to help the needs of people who come to us. And we don't do that terribly well either because of the self-stigma. So until we start addressing our own sector's stigma, and until we start addressing exposing people to the lives of families and persons with lived experience, we're not going to do a terribly good job addressing stigma. So we need to get out there. We need to, not only in training, but once we're in practice, get out and expose ourselves to the lives of families and persons with lived experience, and expose ourselves to the qualities of our colleagues in all the various disciplines. We should do much more research in the multidisciplinary focus, and actually how does your perspective change if you can get out of an institutional setting. I'll just leave it at that.
Thank you, all of you, for, I think, excellent comments.